Henderson, Nevada, and Program Director of Transitional Residency Program and Core Faculty in Internal Medicine Residency Program in Sunrise Health Consortium GME in Las Vegas, Nevada. It's my pleasure to participate in this symposium with our presentation about the cardiovascular outcomes of sodium glucose cotransport inhibitors 2 or SGLT2 and GLP-1 agonists based on race, ethnicity, and gender, and present this systemic review and basically meta-analysis. Diabetes mellitus is one of the main causes of cardiovascular events in patients, in patients, and 50% of their mortality is due to cardiovascular causes. The cardiovascular problems like ischemic heart disease, heart attack, and stroke, together with heart failure, encounters 2 to 4 times more often in diabetic population compared to the general population. Recently, based on the trials, the American Diabetes Association as well as the European Association of Study of Diabetes recommended that patients with established cardiovascular disease, both type of drugs, the SGLT2 inhibitors and GLP-1 agonists, might be considered as a first-line agent or otherwise as a second-line agent after metformin without established cardiovascular disease as per 2019 guidelines. And so we decided to conduct a systematic review and meta-analysis of those 2 classes of drugs, the SGLT2 inhibitors and GLP-1 receptor agonists, and assess their effect on major cardiovascular disease in patients suffering from type 2 diabetes or in patients suffering with type 2 diabetes and heart failure. Our goal is to stratify the MACE risk reduction on patients using those 2 classes of drugs related to the race like white, black, Asian, and others, and ethnicity Hispanic and not Hispanic, and gender male and female. So our goal is to see if the reduction is similar in different races of the major cardiovascular events, genders, and ethnicity. We have conducted per Cochrane Handbook of Systematic Reviews and interventions, in addition to PRISMA statement guidelines, our research. Our literature search, we search Medline as via PubMed, also in Base Corpus, Cochrane, Web of Science, and EBSCO up to 2021 for randomized control trials evaluating the cardiovascular outcomes related to SGLT2 inhibitors and GLP-1 receptor agonists. The eligibility criteria were basically patients with type 2 diabetes or with type 2 diabetes and heart failure with reduced ejection fraction, and we stratified them based on their race, which is white, Asian, black or others, ethnicity Hispanic or non-Hispanic population, and gender, female and male gender. Primary outcomes was major cardiovascular events, which included basically non-fatal MI, non-fatal stroke, or basically cardiovascular death. Together we included also in hospitalization for heart failure and ischemic cardiovascular events. We excluded observational studies, case reports, case series, among others, just included the randomized controlled trials in our meta-analysis and systematic review. First, we did conducted a title abstract screening for eligibility of current studies, and second, we conducted the full text screening. The data extraction was done by 3 independent authors. We used for risk of bias assessment the Cochrane tool for assessment the risk of bias of randomized controlled trials by several domains: sequence generation, allocation, sequence concealment, blinding of participants or the outcomes, incomplete outcomes, outcome data, and selective outcome reporting, and other perception sources of biases. We basically use this assessment to decrease our bias of our study. Quality of evidence: 2 reviewers independently assess the strength of recommendation and evidence provided by the pooled results using the grading of the recommendation assessment grade handbook. So strategy: initially we had 2007 and 1 unique records, and after total abstract screening, as I described in the beginning, we retrieved 73 trials, and of them we basically analyzed 16 randomized control trials. I just wanted to mention that in these 16 randomized control trials which we analyzed for the role of SGLT2 inhibitors and GLP-1 receptor agonists on major cardiovascular events and subdivided them based on race and ethnicity, gender. We had at the end 123,253 participants were assessed, and 9 studies we assessed has SGLT2 inhibitors, and 7 studies has also GLP-1 receptor agonist studies. The number of the white patients was 73,101, 59%, Asians were 8%, blacks are 3%, other races was 3%, Hispanic were 8%, and non-Hispanic population has 32%, which is depicted on our table 1. Basically, the major cardiovascular events in patients with diabetes and high cardiovascular risk, we assessed, and we came to the conclusion that both of the drugs, SGLT2 inhibitors and GLP-1 receptor agonists, significantly reduce the major cardiovascular events. As I mentioned in the beginning, non-fatal MI, non-fatal stroke, cardiovascular death, or hospitalization for heart failure or for ischemic events in white population, with relative risk of 0.87 and 95% confidence interval, and which is depicted on figure 2, an Asian population with a relative risk of 0.7, confidence interval also was 95%. As well, which is depicted on figure 3, and in both males, relative risk of 0.8, confidence interval 95%, which is depicted on figure 4, and females, relative reduction of 0.82, confidence interval 95%, which is depicted on figure 5. While both treatments failed to reduce the major cardiovascular event in black population, because the confidence interval crossed 1, respectively, and other races. But basically we found out that no significant difference was found between SGLT2 inhibitors and placebo among the Hispanic and non-Hispanic population. But on the other hand, basically GLP-1 receptor agonists significantly reduce major cardiovascular events in both Hispanic and non-Hispanic population. I just want to mention that in 2 randomized controlled trials in patients with heart failure with a reduced ejection fraction, the SGLT2 inhibitors reduce the major cardiovascular events in black population with basically relative risk reduction in male 0.79, confidence interval 95%, and females relative risk of 0.71, confidence interval 91%, as well as in white population. So basically stating that those 2 classes of drug did not reduce in black population the major atherosclerotic cardiovascular outcomes, but in the SGLT2 inhibitors reduce in patients with diabetes mellitus and heart failure with reduced ejection fraction. Reduced SGLT2 inhibitors reduce these major atherosclerotic cardiovascular events in blacks as well as in white population, as well as in men and women. I just want at the end to discuss the conclusion of our systematic review and meta-analysis to basically investigate the effect of SGLT2 inhibitors and GLP-1 receptor agonists on major cardiovascular outcomes in patient diabetes mellitus or patient diabetes mellitus and heart failure. We stratified the so-called MACE outcomes based on race, ethnicity, and gender. In patients with type 2 diabetes and high cardiovascular risk, our results revealed that SGLT2 inhibitors and GLP-1 receptor agonists significantly reduced MACE risk in white, Asians, males, and females, but there was no significant difference found in black patients. But in patients with diabetes mellitus and heart failure with reduced ejection fraction, the results show that SGLT2 inhibitors significantly reduce the MACE risk in all subgroups, including the black population. So basically, as a result, we can state that in patients with high risk or established cardiovascular disease, both type of drugs reduce the major cardiovascular events in patients with diabetes mellitus who are white, who are males and females, who are Asians, who are males and females, and also the SGLT2 inhibitors reduces the major cardiovascular events in white and black population, females in males, if the patient, besides the diabetes mellitus type 2, has heart failure with the reduced ejection fraction. But I want to mention that if the patient, according to our meta-analysis and systematic review, is from the black race, those two drugs did not significantly reduce the MACE, I just want to mention that besides the black population and white population with, the black population with heart failure with reduced ejection fraction, there was no difference between the SGLT2 inhibitors and SGLT2 between the SGLT2 inhibitors and GLP-1 receptor agonists, and reduces the MACE in this type of population, but there was difference in the population with diabetes mellitus and heart failure with reduced ejection fraction, which definitely was the SGLT2 inhibitors were more beneficial than GLP-1 receptor agonists. The other thing I want to mention is that, as we know from the studies, diabetes is more detrimental in female patients than in male patients, but interestingly, we have found that in our analysis showed the reduction was higher with SGLT2 inhibitors, slightly higher than GLP-1 receptor agonists, relative risk 0.8 versus 0.89 in men compared to females, while in the group treated with GLP-1 receptor agonists, the reduction of MACE outcomes was higher in women than in men, 0.86 versus 0.89, but these differences were very small. I just want to mention that our meta-analysis confirms what in the past was found in other meta-analysis in Asian patients, in which meta-analysis by causal also was found that SGLT2 inhibitors reduce the MACE events in patients from Asian origin. Here we found that both drugs reduce the major cardiovascular events in Asian patients. This is extremely important because, as we know, the MACE events start at an earlier age in patients from Asian origin. They develop at an earlier age cardiovascular disease as well as renal disease, so at a lower body mass index, and this is extremely important conclusion which confirms the conclusion of causal and other authors. Intriguingly, our results were discordant of the meta-analysis of SYNC, which included 9,285 patients from Asian origin, and basically the study showed a substantial reduction of MACE outcome in Asian patients with type 2 diabetes treated with GLP-1 receptor agonists. However, there was no significant reduction with SGLT2 inhibitors. Here in our study, as well as in studying causal, we showed that in Asian population there was significant reduction with both classes of drug of measure of MACE, which is of extreme importance. As a conclusion, again, I'm reiterating that those classes of drugs reduce the major atherosclerotic cardiovascular events like non-fatal MI, non-fatal stroke, cardiovascular death, hospitalization for heart failure or ischemic events in white population, Asian population, in men and women from both population of those populations, as well as SGLT2 inhibitors reduces the MACE in patients who are basically with from black race, but have on the top of diabetes mellitus type 2 also heart failure with reduced ejection fraction. This is extremely important study which can subdivide what we can use in different ethnicity of the patient, in different genders of the patient, with different risk factors or established cardiovascular disease, as well as heart failure with reduced ejection fraction. We need in the future to conduct prospective randomized control trial for the role of these new classes of drugs in different races, ethnicity, and genders. Thank you very much for your attention.